Hello and welcome to a discussion for the ISN KDIGO webinar, where we will be discussing the results of our recent KDIGO Controversy Conference on dialysis initiation, modality, choice, and prescription. My name is Anthony Bleyer and I will be the moderator. Just a little bit about myself. I did my residency at Johns Hopkins Hospital and fellowship at the University of Pennsylvania, and I've been on the faculty of Wake Forest School of Medicine for 25 years. My research interests are in the epidemiology of end-stage kidney disease and rare inherited kidney diseases. Christopher Chan will be our speaker today. He graduated from the Faculty of Medicine of the University of Toronto in 1995. After completing his postgraduate training in internal medicine and nephrology at the University of Toronto, he pursued further training in cardiovascular physiology. He joined the Division of Nephrology at the Toronto General Hospital University Health Network in 2002. He is presently Director of the Division of Nephrology, Professor of Medicine, and holds the R. Fraser Elliott Chair in Home Dialysis. Dr. Chan is a Deputy Physician-in-Chief of Economics at the University Health Network. He also serves as an Associate Editor for the Clinical Journal of the American Society of Nephrology. So Chris, without further ado, I'd like to turn it over to you.
Thank you, Tony, and also like to extend a warm welcome to everybody on the line. It's truly a privilege to share some ideas with you today, and the topic that we have today for discussion really stems from our KDIGO Controversy Conference on dialysis, and I am truly speaking on behalf of the entire team and consortium, and I'll be doing more acknowledgement at the end of the presentation. Here are my disclosures. I have consulted for various industry partners. And to start, perhaps we can actually delve into the purpose of this controversy conference and this topic. It was noted that there has been significant variation in dialysis practice globally, and also there are mostly opinions and very little guidance. However, globally, we noted that there has been an increase in the need for renal replacement therapy, and we also wanted to really tackle further details in regards to when should someone actually start dialysis, how we should start someone on dialysis, what is the dialysis modality of choice, and why should we actually do the dialysis. And on behalf of the KDIGO conferences as well, we anticipate that this particular conference is really one of several meetings that you will hear about further on in this calendar year and beyond. And so you will see a series of dialysis controversies coming from KDIGO, particularly on dialysis complications, on blood pressure regulations, and further innovations in different type of renal replacement therapy. I'll take the next 20 minutes or so to really provide some highlights within our controversy conferences and also the topics that we discussed. Firstly, the choice of dialysis modality. Second, the timing and preparation for dialysis. Thirdly, access and preparation. And fourth, and perhaps somewhat more controversial, the whole notion of optimal dialysis adequacy and better symptom control. And again, we recognize that the topics also have various point of views, and the purpose of this is for us to have a frank discussion, not necessarily to say that we know for sure what the true answer is. So the purpose is for discussion and actually really drive the progress and identified the need for research within the various topics that I have noted. So regarding the dialysis modalities, the so-called what, our group obviously identified that for generalizability, hemodialysis as well as peritoneal dialysis should be recognized, and that the prescription of these modalities have also evolved throughout the years. We clearly can see that there are conventional prescriptions that we have been accustomed to. More recently, the whole notion of incremental dialysis, both in terms of PD as well as in hemodialysis, have been again rekindled, and that the notion of intensive hemodialysis as well as hemodiafiltration have also been discussed. We thought that palliative and more conservative care were somewhat out of scope for our meeting discussion, so we focus more so within the initial prescription being the top 4 rather than all of them. We understand that the core guiding principle for dialysis really should be chosen at a timely shared decision making type of principle between the healthcare team and patients and carers. We also understand and want to really be proactive about the person-centered approach and engaging the patients to choose dialysis modality more actively rather than passively. The group recognizes that in various parts of the world, the amount of engagement with our patients may vary, but it's more so important to note that we would like to try to move that type of engagement to a much more active and standardized form. I think it's also important for us to realize that starting someone on dialysis, it's not a one-time effort, but ongoing support after starting dialysis and to optimize what the selection ought to be would also be important. I think it is realistic that we need to tailor to our local resource limitation. Globally speaking, not every single jurisdiction will be able to afford and also reimburse the same way. The group recognizes it, but also to that aim, the amount of patient engagement is also going to be very important. Our group encourage and want to support the patients to select a more independent self-care type of dialysis, that being perhaps home-based or even self-care satellite-based dialysis. And we also identify that there are barriers towards these goals. It is important to also understand these type of barriers, and I'm going to spend a little bit more time in the next few slides to actually identify these. If we decide to actually start someone onto a dialysis modality, I think briefly and also broadly speaking, there are obviously chronic kidney disease pathways, and not to belabor the point, there has been a previous KDIGO controversy conference that has already focused on maximum conservative care, so we're going to defer that discussion today. Also, the importance of preemptive kidney transplant cannot be underemphasized, and we also recognize that. Not everybody will be able to have a preemptive kidney transplant, and therefore we think that it is important for us to really engage and also educate our patients towards the both all the choices that's available both at home and also in facility, the various type of modalities that are actually available, are there assistance or no assistance that could be provided, and also the various type of prescriptions that we as care providers can also deliver. So the heat map here at the end here provide us a guide towards the amount of dialysis, the intensity of dialysis, the location, and also the mix of assistance and or without assistance. And again, as I mentioned before, the group recognized that there are barriers towards these uptake, and these could be patient-specific or care-specific, as well as healthcare system-specific. Let me divide them further. And during our discussion at our conference, we recognize that awareness and patient education is a significant barrier. There are pockets of center of excellence globally speaking. However, I think as a community, we understand that there has to be much more effort towards a generalized awareness as well as education campaign. I think it's also important to realize that there are social considerations. There are some patients who do not want to take dialysis back to their home, and that there are also perceptions and fears of dialyzing. Either modalities have specific type of phobias, as well as barriers such as needle cannulation fears, as well as potential body image. For barriers for uptake in terms of healthcare system, there are also many. In terms of accessibility for patients regarding the various type of dialysis may be a deterrent. The distance for actually having home dialysis training programs are also important. The provision of dialysis in other type of facilities, such as extended care type of facilities, would be also a potential for healthcare system barriers. The amount of training time, the infrastructure, and also the actual healthcare variability amongst our various jurisdictions are also important potential variable. I think it's important that we have recognized these barriers, and there are potential ways that we can advocate as well as provide different systems incentives. At our meeting, we noted these particular barriers and potential incentives. We recognize that this is going to require a discussion that's going to take place much higher than our current discussion. But it is important that we flag this, and we want to actually pursue this further. Let's switch gears to preparation for dialysis in terms of the when. Here we see the EGFR dialysis initiation at a DOPS type of survey, and we obviously recognize that there is a significant heterogeneity amongst various countries when someone actually gets started and at what GFR. There are obvious reasons why someone might be actually started earlier, and also vice versa. Nonetheless, we also reviewed our various registry data during our conferences, and have noted that there are some overall trends. Particularly, we noted that there has been a further an appropriate deferral of later start type of dialysis. We also understand that there is an important need for transitioning to a more self-care dialysis modality, and for some regions that requires a significant lead time for education to occur. I think the impact of pre-dialysis care cannot be underemphasized, and in some areas this actually needs to be developed in the first place. So the impact of pre-dialysis care is critical to improve dialysis outcomes, and we also recognize that this requires a multidisciplinary approach. The optimal pre-dialysis care will only allow us to have the timely referral and require us to facilitate dialysis access creation, be that PD and or be that hemodialysis. Here we provided some of the predictors of dialysis start, and we also really reviewed the various models that have been published regarding the risk prediction rules. We understand and we recognize both the advantages and the limitations of any models that can provide us some sort of lead time in terms of starting dialysis. But nonetheless, I think it is important for us to start thinking about the primary care system education and knowledge translation for both screening guidelines as well as coordinating with our laboratory providers to start actually flagging us and as a renal community as a whole. I think it is important for us to recognize that we can't do this by ourselves, and that our group really wanted to emphasize the coordination between our primary care provider systems as well as the various type of risk prediction models and the variables that are needed to actually allow us to actually predict who might be at risk and who are at the highest risk. It is also important for us to recognize that we might want to consider CKD as quote-unquote a reportable disease, so that there are certain thresholds in terms of the kidney risk equation that we could use and also create a notification to various surveillance systems for primary care providers and patients. There are some areas and also some countries that already do that and have a specific electronic medical record notification for all primary care providers who have a screening for both chronic kidney disease, and this is particularly germane for patients with diabetes, hypertension, family history of kidney disease, and also prior acute kidney injury insults. I think some countries also advocate for mass screening initiatives, and there are both pros and cons for that type of agenda. But nonetheless, I think our group as a whole recognize that we need to go upstream to really allow us to partner with our primary care providers to understand the risk. So far, let me summarize. I think we landed on the fact that dialysis modality choices are a significant heterogeneous group. In order for people to pick the choices that best suit them, the most effective means and strategy would be education. We also discussed, and during our 20 minutes, we don't have all the time to discuss everything that we talked about, but the support for carers also requires educational processes. During our meeting, we also talked about the various type of materials that will be needed and also how comprehensive this education ought to be. Let me switch gears to dialysis access and the how. Again, this is a very big topic, and we also recognize that in the upcoming year, there will be various updated versions of guidelines which will highlight the current evidence for dialysis access, both in peritoneal dialysis as well as in hemodialysis. In addition to that, we also understand that there are economic implications for dialysis access, both creations as well as support. There are some biological disparities in terms of gender differences. We also emphasize how transition of dialysis modalities will also impact on dialysis access and vice versa. For example, switching from transitioning from peritoneal dialysis to hemodialysis, as well as going from a crash start type of dialysis after acute kidney injury versus a more independent type of dialysis. Our group wanted to think about the gaps that will need to be researched and inform best practice, and also the various modes of research that will both educate care providers as well as patients. In gender disparities, I think it is important for us to recognize that both biological as well as practice patterns actually have impacted on the various type of accesses that has been created, and also the practicality by which the dialysis access had been used. Furthermore, as mentioned, we understand that there are going to be more and more work that's going to be done from transitioning from one particular mode of dialysis to another mode of dialysis. And I think this is also going to become more and more important as patient survival actually improving as a whole. So transitioning from one mode to another mode will become more and more prevalent. And hence, the life plan of a dialysis access, maybe we'll start with a PD catheter and then switching over to hemodialysis. How should we do this? How do we do it in a timely fashion? And what is the right approach needs to be focused. I think it's also important for us to start thinking about the order of dialysis access. And here I just listed some examples that have been discussed during our meeting. And there are more and more potential models that you can think about. For example, patients coming from a transplant, coming back to dialysis. Someone started on hemodialysis who decides to actually switch over. And more commonly, peritoneal dialysis switching over to hemodialysis. How do we individualize it? What is the best approach? and is it one size fits all? I would acknowledge that this is a significant amount of work, and other committees and also societies have also updated that. I would just mention that overall, the take-home message that we would like to impart is the right access for the right person at the right time. Let me switch gears to the last part, which is adequacy. Currently, adequacy for decades have really been defined based on small solute clearance, well, either with KTORV or urea reduction ratio in hemodialysis, more so in creatinine clearance, and still with KTORV in peritoneal dialysis. It has been emphasized in clinical guidelines previously. It also formed as a basis for clinical performance measures, which sometimes have been tied to payment in different countries. And in some jurisdictions, many clinicians actually look at this as dogma. However, I think most of us within our group noted that K2V is a measure of only one of many aspects of dialysis care that are likely to affect outcomes. So in our meeting, we're proposing that we should really think about a more comprehensive paradigm shift. We favor a more umbrella concept than what is currently being offered and what is currently referred as adequacy. In fact, we feel that there should be more dimensions to dialysis than just small solute clearance, and that there are multiple components that had to be looked after. And these are listed here in some components. For example, how much residual kidney function does the patient have? What is the volume status control? How about the other biochemical measures, the nutritional status of the patient, and also equally important from a symptoms and patient experience point of view. We should also incorporate both the goals of the care providers as well as the goal of the patient. After all, how do we define success? It should never be a singular unilateral type of goal. So adequacy really have very different meaning for both patients as well as clinicians. So with that, we would propose a terminology change and also a concept change. From a terminology change, we debated quite aggressively what is the best terminology change from adequate dialysis to what. And there are various terms that has been offered: optimal dialysis, high quality dialysis, goal-directed dialysis, individualized dialysis, patient-centered dialysis, and our group ultimately landed on goal-directed dialysis. And the meaning for this really stems from the fact that we wanted to have a shared decision-making type of model between the patient and the care team to really establish what would be a realistic care goal to allow the patient to meet his or her life goals, and also to allow the clinician to provide the best individualized, high-quality clinical care. We recognize that components of goals could be affected by the dialysis procedure itself, but also have a significant component which is reliant on the patient and the self-care management. That also, once again, emphasize the whole utility and the importance of the educational aspect of our patients. Once again, this isn't going to be a one-size-fits-all type of solution, but rather this is going to be a shared responsibility between the care provider as well as the patients. So in terms of solutes, we're not saying that small solute kinetics is not important. And in fact, all solute kinetics are actually should be interpreted, and also within the context of the patient's overall goals and clinical status. Small solute should still be measured, and it's really, if you like, a minimal amount of goals. And that if we achieve only the KTOV of small solute, that has allowed us to achieve really the lower bar of dialysis rather than the quote-unquote higher quality goal-directed dialysis. And in here, this is where research is needed to really investigate the other roles of other type of solutes, both middle, larger molecules, and also protein pound and carbamylated molecules. And we also understand that there are now newer knowledge in terms of intestinally derived substances and other potential uremic toxins, and even the whole role of epigenetics in terms of our uremic toxicity. So in summary, dialysis adequacy, we felt that it's not an ideal term, and it sends the wrong message. It indicates the goal is to be quote-unquote good enough, but I think we want to strive better than that. We advocate that we will need to move away from the one-size-fits-all approach and provide more individualized care, and that we want to identify and achieve the goal-directed dialysis that I just mentioned. This will require a realignment of the tools, both for providers as well as patients, and to a certain extent, some of the incentives that drive our current practice. We recognize that there will be needs. There will be needs in terms of research, in terms of the various types of solutes, how we actually measure uremic toxicity as a whole. We also recognize that there are a lot of work that actually needs to be done, and also perhaps innovate in terms of how we do the dialysis. What will be the appropriate composition? And also, how do we actually change what we currently do? We understand that there are now more and more importance in looking at dialysis frequency and duration, and also volume status, both in terms of assessment and management. There will be some patient-centered outcomes that includes patient-reported outcomes, which will drive this goal. And there will be importance of developing and implementing these strategies. We understand that symptoms may be able to be assessed, but sometimes could be prevented or managed. And this could be done both during dialysis or at least outside dialysis. With the amount of time that we've spent, I'd like to end my presentation today with several acknowledgement slides. Our meeting was co-chaired by Dr. Carol Pollock, and also we have 4 groups of group leads in terms of the 4 topics that we talked about. Dr. Peter Blackstein, Dr. Laura Denver, Dr. Lorenzo Galliani, Dr. David Harris, Charmaine Locke, Raj Malhotra, Paul Stevens, and Angela Wang. And I'll also like to acknowledge all the conference participants that really formed the collective of the knowledge that I just presented to you. And the final thanks to our KDIGO executive and leadership, including Mike Chung, David Wheeler, and Wolfgang Winkelmeyer. And finally, a thank you to all of you that logged on and listened to our presentation. And our resources and materials are now available at the KDIGO websites for people to also look and understand some of the work that I just mentioned. We envision that we will have a conference paper that will come out in peer-reviewed publications. And with that, thank you again, Tony, for your moderation, and I welcome people's comments and questions. Thanks.
Chris, thank you very much. That was a really nice talk and a very nice summary of our meeting. I'd just like to ask everybody, there's a place on the right side of your screen in the dashboard where you can ask questions, and then we could entertain those questions. Dialysis delivery should focus on, please select 1, achieving meaningful targets, optimal dialysis symptoms control, optimal resource utilization, or all of the above. And the results show that 80% thought that the answer for this question was all of the above. 11% thought dialysis delivery should focus on achieving meaningful targets, and 8% thought that optimal dialysis symptom control was the most important. Chris, what are your thoughts on this?
Well, I think that's interesting. I have to tell you that during our meeting, we also have a mix of what is the most important. There are certainly a number of people who thought that solute control is still the most important. I think that has now been softening to combined with both solute volume and symptom control. But I welcome everybody's thoughts because I think this is going to be an individualized type of approach. In addition to that, there is some constraints within what is reality. We can talk about frequent dialysis, we can talk about intensity of dialysis and dialysis education, but in some parts of the world that may not be a practical approach, and that might not be a feasible thing. So I think it would be important that we recognize that and also allow people to understand the background, what we thought would be the best way to move the field forward. But I certainly acknowledge that this may not be achievable everywhere in the world.
Yes, I think it's a very difficult situation for us as nephrologists. So, for example, achieving a certain KT over V, this gives us a number that we're able to achieve and we're able to look at on a month-to-month or even weekly basis.
Right.
But then obtaining optimal dialysis symptom control is a little bit more complicated. So, for example, I could have a patient who feels very well with a KT over V of 1, but I'm worried that this patient may become malnourished, and if I kept them at a low dialysis dose, that they may develop symptoms of weakness, anorexia, and malnutrition over the next several months. And I think it's very
Yes.
hard to take into account those two things, and I think it's an area where we need more research.
Yes, and I think this is where the goal also needs to be number one, documented, but also secondly, presented. There was a lot of heated debate in various working group in individuals where are now starting dialysis that tends to be older, that tends to have more comorbid burden, and also may have other illnesses that actually might be a competing risk for death and end-stage kidney disease. Is that a realistic goal that we can provide the best quote-unquote optimal therapy in trying to check all the boxes? Or should we actually have a more realistic discussion? So, for example, in the dialysis access group, there was a significant shift in the paradigm from the fistula first type of idea to saying that is this actually an appropriate candidate for fistula first? And I think that there is now a pendulum swing to think about our patients to say what is actually a realistic goal here. And in addition to that, I think KT-OV allow us to have a practical number that people feel confident in, but that KT-OV of 1 may seem to be okay, but nonetheless, that doesn't include phosphorus, both high and low, and also other type of important uremic toxins. The most hidden one and not identified with any of the numbers is actually volume control. You can have someone who actually check okay with biochemical clearances, but have terrible volume control and interdialytic weight gains and so on and so forth. And you and others have already identified the fatality associated with the intermittency of dialysis, and that's something that we also wanted to bring light to during this conference and also other conferences that's coming up.
We have a question here that I'd like to discuss. It's from Augusto Cesar Suarez dos Santos Jr. Here's a question. Supposing the different methods are equivalent in terms of efficacy and that costs are not necessarily the same, how can we put into perspective the possibility of personalized care and the predictability of budget to cover the costs? Can you comment on that?
Right. So That's a very important question, also a difficult question. So assuming that all outcomes are equal, and that might be true. Let's say in the context of 3 times a week hemodialysis versus peritoneal dialysis. Let's use that as an example. The 2 most broadly used type of therapy, and in broad strokes, the outcomes are about the same. However, resources and also cost are different. And it was interesting, and we discussed that during our meeting, that cost is very different in one country versus another. And what we thought might be more cost effective in one country is not necessarily cost effective in another country. And the type of resources that's available in one is not available in the other one. I think if all resources, if all therapy are giving us an appropriate equal amount of outcome, then I think resource allocation and also we're dealing with scarcity of resources has to be taken into account. And I think in that case, then we need to actually maximize the best available resources for the most patients that we can actually deliver the care. But I also welcome the person that actually posed the question in terms of what he felt might be the best answer to this.
All right. So then we have another question, and this is, or actually we're going to try to do, all right, here's the other quick poll question.
Oh, here we go.
There are multiple barriers towards optimal dialysis start, including, please select 1, the lack of dialysis modality education, the lack of access discussion, discussion of dialysis goals, all of the above or none of the above. Okay, and we can see that, as you might expect, people commented that all of the above are really barriers towards optimal dialysis: lack of education, lack of access discussion, and discussion of dialysis goals. Chris, would you like to comment on this?
Yes. So thanks. The poll is, I think, a symptom of the entire reason behind the conference. I think the current practice of dialysis requires a reboot of these 3 important goals. I think the dialysis modality education and CKD education cannot be underemphasized. And this goes hand in hand with dialysis access. If someone is educated about dialysis modality, then the dialysis access will follow. And at the same time, the goals of what dialysis ought to be able to achieve can be discussed. More often than not, our panelists as well as our group during our discussion recognize that this isn't being done, and therefore the whole reasoning behind the present discussion, our controversy conference, is really trying to reshape how we do our practice. I think we owe it to our patients to really change what we do, because without these 3 items, we will never be able to actually get the initiation, the choice of modality, the prescription, and the access in place. And this requires not just physicians, but our entire team, and also collaboration with other partners. So I agree with the group online, and this is why we needed to have our meeting.
Yes, and I think it's emblematic of a lot of things that we're seeing in general in medicine today, of going to a more patient-centric approach, and that
Yes.
we really haven't focused enough on the patients. We've presented information about dialysis modality and access from our standpoint. You know, everybody should get a fistula. Both modalities have equal survival, but we haven't really reached out to patients as much to listen to what they say and to take into account what they want to do.
Right. And during, if I can add as well, Tony, during our discussion at the meeting, some participants have borrowed the model that oncology have used. And I think oncology may have some further research on this as well in terms of tabling and also identifying the various type of modalities, as well as the goals and the outcome that the patients may be able to derive from. And I think we may want to think about our practices in that type of fashion. And once again, this requires a fundamental pendulum swing of how we actually provide care.
So we have some comments from Augusto, who asked the first question, and he said, I live in Brazil, and in our country, dialysis is broadly offered in the public healthcare system. However, some modalities are not available specifically due to cost and scarcity of resources. Specifically, our public healthcare system covers peritoneal dialysis and conventional hemodialysis. So yeah, I found that was something that was really difficult for us to take into account in this KDIGO Controversies conference, all the different countries and how each country approaches dialysis in a different way. And for many countries, the dialysis, fortunately, is supported by the government. But then this means many different governments supporting it in many different ways. And it was hard for us to kind of wrap around our arms around that concept. Chris, what were your thoughts on that?
Yes, there is. I think rather than having a utopian view, we decided to recognize that there is variability around the world, and there's also scarcity of the amount of financial support for dialysis, and this heterogeneity works both macroscopically as well as in the micro view. We understand that there are for-profit dialysis companies, and also we understand that there are countries that only will be able to have the most fundamental dialysis provision there. Having said that, we acknowledge that this is a limitation, but we also understand that we have to start somewhere, that we need to educate ourselves in terms of chronic kidney disease, education, and modality as a fundamental aspect of all nephrology practice as a whole. We also understand and should acknowledge that in some countries where financial reimbursement is provided for various types of dialysis, that viewpoint does not always necessarily translate into a better distribution of modalities. So even in countries where finances may seemingly be viewed as not a barrier, the distribution of modalities seems to be out of keeping from what we thought might be a better distribution. So I think there is a lot of work to be done, both in our own practices as well as how we disseminate and share our knowledge with our patients.
Okay, we have another question that came from Onwin. Could you explain the trend of switchover from hemo to peritoneal dialysis is less common than the other trend of switching from PD to HD?
Okay, I think that really underlies the practice pattern as well as the technique survival of various type of modalities. In terms of peritoneal dialysis switching over to hemodialysis, we and others have examined in various registries. This is the most common transitions of dialysis modality. And also, just as a by the way, it is also in every single time that someone transitions from one mode to dialysis to another mode of dialysis, that's associated with a heightened amount of hazard, both in terms of hazard for death and also hazard for other morbidities. I think the trend for PD switching to hemodialysis is more common that's basically underpins the natural history of the various type of modalities, and perhaps also the amount of support that someone actually requires going from a home-based modality to a more support. So I think this has this is really a loaded answer to suggest that one, there's differences in practice patterns. Two, the reason why I don't think that we see more hemo over to PD is because I don't think that people are actually following up patients started on hemodialysis rather, to actually educate them more about the potential for home-based modalities later on. And that speaks also to in-center hemo to PD, as well as in-center hemo to home hemodialysis as well. So your question highlights the CKD education as well as modality education that needs to happen.
Yeah, so just to add to that, I think I would agree with everything Chris is saying. And I think especially of one of my patients who started PD as an example. So patients, when they start PD, they're usually independent and they're interested in staying independent. And so she was on peritoneal diet. And we also do a much better job incorporating residual renal function into peritoneal dialysis dose. So when our patients start PD, when this lady started PD, we started with a lower volume. Over time, we built up, and she gradually lost residual renal function in over 12 years. She did very well, but then started to become more frail, had no urine output and membrane failure, and then we made the natural switch to hemo. Whereas our hemo patients, to me, from my standpoint, a lot of them, they make the choice early on that they would rather go to the dialysis unit than to do it independently. And then as they lose residual renal function, they become somewhat less of a good candidate for PD. And as they become more frail, they also lose that. So I think that may be a reason. We have a question. Oh, go ahead.
Oh, good. Let's go to the next question.
We have a question from Shankar Prasad Yadav. Sometimes in the developing world, people have very little idea about dialysis or are not able to understand much. In such settings, how would you describe the role of the nephrologist in helping them opting for a choice?
Right. And that was also brought up during our discussion at our meeting. We have a representation all around the world, and in some countries, the entire treatment choice of dialysis is not recognized. So I think this is where the ISN as a whole, as well as advocacy groups and outcomes groups such as KDIGO can make a difference. And I'm hoping that through education sessions such as this one, and also our meeting proceedings, to highlight this unmet need and this gap of education. I think from a nephrologist perspective, it is really our job to try to allow patients to understand that number one, dialysis exists, and also number two, dialysis can exist in various modality and forms. And renal replacement is not only dialysis, but also kidney transplant as well. And then the last thing that I would say is that during our meeting, we also acknowledge and recognize the financial implication, and certainly in some developing countries, of the impact or the burden on the patient if one needs to start on dialysis, and that could be catastrophic. And we understand that. Again, it is beyond the scope of our meeting to try to solve everything, but we highlighted that as a need and also an action. And this is beyond just the nephrology community alone. This will require both political as well as other type of advocacy.
Okay, we have a nice comment from John Uman. There's perhaps the notion that going into a hemodialysis center gives an opportunity for a person to be in constant touch with the health system as against someone who is by themselves trying to manage a kidney disease at home through PD. I'd like to just take a stab at that one quickly because I do find that also is an issue. And so a lot of times when I'm talking to my patients about starting dialysis, I really try to emphasize to them that we will teach them how to do PD, but it's not like in school, you know, where you cover a topic and then you have a test and you're all on your own. I find that that's difficult, I think, for patients. They don't realize that a lot of the times. And so I think it's very good that we're able to go ahead and really emphasize to patients, you know, once you go home from the peritoneal dialysis unit, you always have access.
Right. And I agree with you, Tony. I think this is also the notion of education. The education or the perception that patients have regarding home dialysis out of sight and out of mind ought to be corrected in the sense that we want to make sure that our patients who are dialyzing at home have equal amount of support, or if not more. And there are innovations in the care models that are being done around the world. Different groups are using telemedicine, virtual rounding, as well as different type of connectivity to fill that gap. And in addition to that, it is important for our care team to be proactive to actually follow up with our patients. So I think that actually highlights an education gap in terms of modality choice, and also that we have the technology to probably provide a different way of service for our patients in addition to what is conventionally being done.
Okay, we have a question from Musa Traore. Is there now another consensus about starting time for diabetes patients?
Well, I think that's a loaded question. Patients with diabetes tends not to just have diabetes at the time of needing to start dialysis. More often than not, they often will have cardiovascular morbidity, which tends to be somewhat of a driver in addition to uremic indications. And in some of our discussion, we recognize that, and certainly potential volume overload and cardiac systolic dysfunction was discussed. And I think this is where I think the symptom control is just as important as uremic solute control. We also discussed about the various type of modalities that might best protect residual kidney function, as well as providing volume ultrafiltration control. So, for example, in those type of circumstances, as already mentioned by Tony earlier, peritoneal dialysis might actually provide adequate UF, while the solute is actually not the driver. So I hope I answer your question appropriately.
Okay, very good. And we have one last question. Hi, I'm Pablo Vallejo from Colombia. I'm a pediatric nephrologist. My question is, how do you manage a patient with no vascular access or continuous peritonitis? I ask this because it is very common in this population, knowing that kidney transplantation is always the main goal. Thank you.
Yes. And just to add, Pablo, thank you again for your question. We also have pediatric representation during our discussion as well. Again, time didn't allow us to go into all the various subgroups such as pediatrics, pregnancies, and so on and so forth. It is a real concern from what I understand from the pediatric discussion I'm not a pediatric nephrologist. I don't live in that world. But my understanding from our discussions with the pediatric nephrologists were that, number one, usually kidney transplant is always the preemptive form, and that PD is often used. The lack of vascular access is troublesome. I don't think it's any different than in the adult world as well. And in fact, in many countries, the lack of access will then propel the patient into a priority for kidney transplantation.
So I think you've done a really nice job summarizing, Chris, and I really thank everybody for participating in this conference and for the questions that you've asked. And we really much look forward to, if you have any other questions, you can email us at education@theisn.org. And I'd like to just thank everybody for participating and look forward to the next time we're together on one of these webinars. Thank you very much.
Thanks again, Tony.